what assistance is available and what does the specialist do? Well, specialist referral is indicated for the more severe symptoms, particularly those with a significant impact on quality of life. Those in whom those first-line measures haven't proved effective or there are still persistent troublesome symptoms, and perhaps those in super high-risk groups, younger patients, postpartum following anal sphincter injury, and those where there has been previous surgery, because they tend to be a little bit more challenging to manage in primary care. Not impossible, but a little bit more challenging. And you need to look for specialist care centres with multidisciplinary team approaches, because I've alluded to the fact that the needs of these patients are complex, with many different specialists and allied health professionals needing to be involved. But there are also evolving technologies for assessment and a rapidly expanding spectrum of very effective interventions for treatments. So I'm just going to finish up by talking about a few of these strategies that we use in specialist care. So if we take a group of patients with fecal incontinence, gone are the days where we can apply one empirical treatment to the entire cohort, because they're heterogeneous in terms of their underlying pathophysiological reason for developing their fecal incontinence. And we use sophisticated anorectal physiological investigations to help identify more homogeneous subgroups of patients, for example, those with anal sphincter weakness, those with rectal reservoir dysfunction, those with heightened colonic transit, and those with denervation syndromes affecting the pelvis, to then tailor our most effective interventions. So what are anorectal physiological investigations? Well, they're the bowel equivalent of urodynamics on the bladder. They comprise a suite of related investigations involving anorectal manometry, pelvic electrophysiology, and endoanal ultrasound, where we undertake comprehensive functional evaluation of the pelvic floor and the anorectum, and also some structural assessment of the pelvic floor musculature and specifically the anal sphincter complex. So here's an example of some of our anorectal manometry equipment to measure anal pressures. This is now very dated equipment from the last millennium, in fact, from the late 90s. It used to give quite unsophisticated, primitive, rudimentary traces. And this has given way, thankfully, to more modern equipment in the same way that colour TV and high definition and high resolution TV has replaced the old black and white television. That's exactly what's happened with anorectal physiology. And now, rather than having those rather rudimentary looking traces, we have this anatomical topogram, and you can see on the right of the screen a schematic of the anorectum, and if you cast your eye to the left, the rectal area shows the pressures in the upper part of this topogram, and then this central region that the eye is drawn to in the middle of the screen is the zone of the anal sphincter muscles that is paralleled by that schematic shown over on the right side to show you that we're in the level of the anal canal. And the pressures measured are colour-coded, so the red, warm colours are high pressure, and the blue, dark colours are of low pressure. And you can see this is a reasonably normal-looking trace, because there are, through our zone of the anal canal, we can see nice warm colours reflecting normal anal canal pressures. And we can contrast that with this trace, where we can see decent colours revealing reasonable pressures at rest. But when we ask the patient to do a voluntary squeeze to test external anal sphincter function, you can see there's barely a change in colour, just a slight change in colour. And this would reflect external anal sphincter dysfunction. And then we've got our structural evaluation of the anal sphincters using endoluminal endoanal ultrasound. This is our historical sort of images we used to get from ultrasound. And these have now given way again in the 21st century, thankfully, to three-dimensionally reconstructed images. And on the right of the screen here, you can see this dark zone in what is otherwise an echoic, the snowstorm appearance, white area in the sphincter complex, extending from the anal verge up the anal canal, reflecting an external anal sphincter defect, which was the explanation for those attenuated squeeze pressures on that previous trace.